to hear this talk. So as some of you know, I live in Fredericksburg, and a few months ago I was reading our local news and I saw this great article about somebody who was local and had gone to New York to do some fatality management some fatality managing issues during COVID. So I reached out to him on LinkedIn and explained about our program and our webinar series, and John was agreed to come speak with us. So he's been working in emergency response and management for over 27 years, and he's served as the Deputy State Coordinator for Disaster Services at the Virginia Department of Emergency Management, as the incident commander of the New York City Hurricane Sandy Debris Task Force, where he was charged with overseeing the removal of all storm-related debris in New York City, and as the New York City Office of Emergency Management Deputy Commissioner of Operations. He's also served as the Deputy Director of the Special Operations Division of the New York City Office of the Chief Medical Examiner, where he also oversaw operations and safety for the World Trade Center Potential Human Remains Recovery Project, and he managed the ME Special Operations Response Team. For 14 years, he's worked as a member of the New York Police Department, where he retired as Commanding Officer of the Emergency Services Unit HAZMAT WMD Response Team and Training School. He was also a member of the NYPD Elite Emergency Service Unit, and he was a member of the DoD Combating Terrorism Technical Support Office Technical Support Working Group as a CBER and subject matter expert for 15 years. And I know a lot of you are interested in that from all of the surveys that I've gotten from 410. So right now, he serves as the Director of Safety, Security, and Emergency Management for the Virginia Department of Transportation. So John, thank you so much for speaking with us tonight, and I will turn it over to you.
All right, thanks, Jen. It's always uncomfortable when people read your bio, especially where it sounds like I've been jumping jobs since I left the NYPD. Sometimes when you retire young and opportunity knocks you, just keep moving. All right, well, good evening, everybody. Looks like we got a nice intimate group here, which is great. So if you do have questions as I'm going, use the chat feature or raise your hand. I've asked Jen to interrupt me as we go through this. But thanks to you, Jen, for organizing this and making the logistics on me very easy. I hope you all find this informative and take away a little piece of knowledge about fatality management, and hopefully you'll never have to use it. But unfortunately, as we've experienced in 2020, anything is possible, and history seems to continue to repeat itself. So what I'm going to try and do is I'm going to go walk you through some of the high-level concepts and an introduction to fatality management and some of the terminology that I think is important for you to understand if you're ever in one of these situations. So I've been involved with fatality management for most of my public safety career, but I didn't really understand what that meant or understand that I was involved in fatality management until after 9/11. So let me explain what that statement means. So as Jen mentioned, as a member of the NYPD, I would respond to calls all the time where people were killed or injured and likely to die. And I was the tip of the spear, right? I was the first responder there. And I got the fatality management operation started. And my actions could either help or hinder the entire investigation. As a member of the NYPD's Emergency Service Unit, we worked and we assisted in the recovery of decedents from various, different situations. People on the trains, people died from chemical contamination, auto accidents, people stuck on the balconies of buildings after they jumped. A lot of different, situations. But for us, it was do the recovery, transfer the remains to the medical examiner's office. So by definition, this was fatality management, but I truly didn't understand what that fatality management system was and how it worked. And after my part of the response was complete, we, as public safety first responders, we pack up and we leave. So after 9/11, unfortunately, I got a education on fatality management and have been learning more and more about the intricacies of fatality management for the last 19 years. So tonight, I'm going to give you a look behind the curtain, hopefully, hopefully pique your interest, and you'll learn a bit more about, this complex subset of public safety. So again, I've asked Jen to, monitor the chat, and if you do have a question, I'll pause at certain points. My staff often tells me that I could fill an hour-long meeting and never stop talking. So I try to be cognizant of that, and purposefully pause, and hopefully engage you folks. If any of you are interested in turning on your cameras so I could see head nods or any kind of interaction, I do this all day long now, like probably everyone else in professional world, and I do find it helpful rather than talking to your little icons there, or your Bitmojis. All right, so what is fatality management? So CDC put a definition to this, and I'll read through it. It's the ability to coordinate with other organizations, law enforcement, healthcare, emergency management, and the medical examiner coroner, to ensure the proper recovery, handling, identification, transportation, tracking, storage, and disposal of human remains and personal effects, certify cause of death, and facilitate access to mental behavioral health services to the family members, responders, and survivors of an incident. Now, Jen, I took some notes as you were doing your opening, and you talked about, mental health services that are available to the students and to the faculty, and I applaud that. And it's, something that, we've worked on in public safety, and a lot of us haven't really mastered it. It's super challenging to intervene with coworkers, when you see them having problems. It's a cultural thing. I've done it. I've had people, I've lost friends because of it. I've gained friends because of it, but you sleep better, knowing that you've interceded with somebody. So I applaud the group. All right, so I want to talk through fatality management as a system. People die every day. When I interviewed to work at the medical examiner's office, the chief medical examiner at the time in New York was Dr. Hirsch, who's a legend in the medical examiner coroner field. And the only question he asked me when I got to his level was, what's the mortality rate in New York City? So I had to think about that. I'm like, I'm not sure, sir. I think it's high. He said, yeah, it's 100%. Everybody's going to die. And he goes, a lot of them are going to come here. Nobody lives forever. He goes, you know anybody that's lived forever? And it was just the most bizarre job interview I'd ever been on. But when you think about it, his approach was very practical, where their business is super technical and scientific. It starts either in public or at a hospital or in your home when someone passes. But during a disaster, it takes on a different tone and a different pace. And I'll try and talk you through some of that. So why do we do fatality management? So what's the purpose of it? Like I said, everybody's going to die, but we do it for the living, right? Part of my deployment up to New York back in April, Time Magazine did a great article on the operation there, and it was titled, "We Do It for the Living." And that's a statement that, one of my mentors always said in this business is, you're not going to bring anybody back from the dead, but you want to bring closure to those families. And, the dignified transfer of remains and the handling of those gives the next of kin or the family's closure. And that's why we do it. And there's a lot of steps to get to that, and it's time consuming, but you're not doing it for that poor person that's, lying there, unfortunately deceased. You're doing it for whoever their loved one is. And that's why we do fatality management. So let me just talk you through a few of the steps. So I'm sure people generally understand this, and I'm not sure of who the audience is and what your experiences are. So I apologize if this is too simplified, but we can talk through that at the end. So if someone passes either at home or in a medical facility or in the public, depending on where they pass and the circumstances about their passing, there are a few different paths that can get followed. So a natural death, someone that dies from natural causes, are usually not the jurisdiction of the government. So the coroner, the medical examiner may not get involved. They may respond to a house to, certify that a death was by natural causes, and then a family physician or a hospital doctor will sign a death certificate. But unless there's some kind of circumstance that makes it suspicious, usually the government won't take jurisdiction, right? So a heart attack, a stroke, natural causes, COVID, which I'm going to speak about here in a minute and why that's complicated, are all considered natural deaths. So the other side of the coin is other than natural deaths. So traumatic events, workplace incidents or accidents, victims of crime, natural disasters. I'm sure the folks down on the Gulf Coast, saw some of the response from the recent hurricane that made landfall. They had, at least a dozen deaths that I saw. Those are all other than natural causes, and normally they become the jurisdiction of either the coroner or the medical examiner. The common theme is, all paths lead to two common places. The system starts with someone passing. The system ends with someone either being cremated or buried. There's really no other place. I mean, you can donate yourself to science, you can do a few other things, but you're usually going to end up either cremated or buried. What happens in between those two, points, death and burial or cremation, is that fatality management system. And the steps that are taken in there, I'm going to talk through those. So a couple other things that you need to understand. The difference between a coroner and a medical examiner system. And you probably heard these terms, but they're not the same. So the major differences between coroners and medical examiners are embedded in the manner of their selection by electoral process versus appointment and their professional status. So coroners are an elected official. A medical examiner is a medical professional that is appointed, normally certified by a board. They're an MD. Some states, like Virginia, has a centralized medical examiner system. So the state has jurisdiction over all non-natural deaths. They also oversee, the signing off and the documentation of death certificates. There's, some other technicalities in there. But the majority of the country has coroner systems, which is an elected official who then brings in their own medical staff to oversee, autopsies and identifications. So understand those two differences of, elected official versus medical professional. And when you see, on the news, the coroner's office, that is a political elected official. If you see a medical examiner's office, that is somebody that was appointed by the local jurisdiction, the administrator in charge, the mayor, whoever it is, in our case in Virginia, appointed by the governor. So another term that you need to understand in this is cause and manner of death. So what's the difference between the two? The cause of death is the specific injury or disease that led to your death. So the cause of death would be COVID, right? That is the specific disease that caused your death. The manner of death is the determination of how the injury or disease led to your death. So with COVID, a lot of people, it's a pneumonia, or it's natural. It would be determined natural, right? So the manner of death would be natural, but the cause of death would be COVID. So there's only really 5 major manners of death: natural, accidental, suicide, homicide, or undetermined. The cause of death could be all kinds of different things, all kinds of traumatic injuries, but the manner is always one of those 5. So a death certificate, let me talk through what that means. So death certificates can either be signed by a private doctor or the medical examiner, coroner, appointed, forensic pathologist. That caused some challenges in New York during COVID, and I'll talk a little bit about that at the end. And I will talk about that, in the planning section when I get to that here in a minute, of why it's important to understand. You want to try and keep your processes the same during an emergency and during a disaster, but you also need to have enough flexibility where if that's not working or it's hindering your response and recovery, that you might need to modify that. So keep the death certificate piece in mind. So again, let's just go back to the from death to final disposition of cremation or burial. So you have the death, you have the possible investigation that's going to determine cause and manner of death. Within that, there's going to be identification, which I'm going to talk through here in a minute as well. There's the transportation to and from either the scene or the hospital to possibly the medical examiner's office, and then to final disposition, and then again, final disposition. So the medical examiner, the fatality management system kind of encompasses, those major categories. Now, it's obviously subsets within all those. And I'm going to take a pause here and just see if anybody has any questions before I continue on.
John, this is Gene. Yeah, I do have a question. So I'm sure this is a general question, but how often does the manner of death change from your first inclination?
I don't think it does that often. From the discussions I've had with the MEs, specifically in New York, and friends with the just recently retired coroner out in Las Vegas, it doesn't change that often, especially if it's a medical examiner or coroner case, because they will not issue the death certificate until their investigation is complete. Now, in a hospital setting, on a death certificate, they'll have cause and manner that the hospital put down. And that family may request an additional investigation because they disagree that, that heart attack killed my, loved one. And the ME may elect to take that case and do a further investigation and maybe find that there was, a malpractice or, something of that nature, which would be considered an accident. So sometimes, it's possible that something can go from natural to accident, something can go from, suicide to homicide, but I don't think it's common. I think they, know their craft very well, and they're very meticulous about how they, go about, determining those cause and manner of death.
Thank you.
Yes, sir. All right, so I'm going to talk about some of the challenges during a pandemic, and these are some of the things that we experienced up in New York. So, as I mentioned earlier, a death from a pandemic, from COVID or Spanish flu or any of the other, natural outbreaks of disease, are just that. They're considered natural deaths, and usually natural deaths are not the jurisdiction of the government, the ME or the coroner. They're, handled by family physicians or hospital physicians, and they're able to sign off on the death certificates. So the hospital healthcare facility would work directly with the funeral home, funeral director, or the families to execute final disposition. So if someone dies at home and is determined to be, pandemic related, COVID related, natural causes, the family would work with the family doctor to get them to sign the death certificate, and then the funeral home would, work to execute final disposition. So what's the challenge there? So the challenge that was experienced in New York was really a numbers problem. The system is built kind of just in time. 45,000 people a year normally die in New York City, total. Natural causes, non-natural causes. And the system is built to be able to handle that many deaths and that many final dispositions and that many burials and cremations, because historically, like any other business, they have a throughput. They understand what their workload is. Well, now you put 45,000 deaths in 5 or 6 months, that's significantly going to stress the system, because they don't have enough staff at the hospitals to handle that many decedents coming through. They don't have storage at the hospitals or the nursing homes. The medical examiner's office in New York doesn't have the storage for that many decedents. So it really becomes a challenge, because people are dying. There's not enough storage to keep them in cold storage, or even if you can embalm them all, the funeral homes don't have the capability to store them all. Even if they did, there's still a backlog, because there's only so many crematories, and the cemeteries don't have the staff. So the challenge and you're butting up against that at the hospital level with keeping people alive, which is obviously the priority, right? So you don't have the staff commitment to put it in the hospital morgue to try and handle this logistical problem of way more numbers. And now you have to come up with a mechanism to store them, track them, transport them, store them again, and then hopefully work with the funeral directors at some point to execute final disposition. And I'm sure some of you saw some of the news media out of New York where some of these funeral homes had, people piled everywhere. They were in trucks. We had one place that had bodies in a minivan out in the parking lot just because they ran out of storage. It was very disrespectful. And, the city was smart enough to step in and take control of those remains. So the biggest challenge that we saw was on the front end, the numbers. Now, New York City had a robust plan because they knew this would be a challenge, but the timing was so rapid when the onset of this came, and it went from 10 to 100 to 1,000 in very quick amount of time to get that system ramped up, to bring on the additional disaster morgue facility, to bring on the refrigerated tractor trailers, to bring on the freezer units, because after 30 days you don't want people in refrigeration. You really need to freeze them so you stop decomposition. And again, just getting personnel and contractors to come work at a disaster morgue is challenging. If a refrigerated tractor trailer broke, the responding person to come fix it would ask the question, because he'd look around and see, what was going on, and people in PPE and hearses coming through. What is this place? Oh, it's the disaster morgue. There's 3,000 decedents in that building in refrigerated storage. Turn around, drive right out of the parking lot. We'd have to find another technician because people would not want to work in those conditions. So that's some of the high level challenges. There's a lot of, and as I mentioned earlier, the piece about keeping your plan flexible and having to don't have your plan so rigid where you're afraid to change things. We made some significant changes to the plan, actually to the administrative processes in New York City of handling decedents while we were doing this, and it all started to work very well. And knock wood, hopefully there's no wave two, but they're prepared, with the logistics, with the personnel, with the experience to quickly move into this if they have to again. All right, so let's talk quickly about, and in the announcement, Jen sent out, it mentioned kind of talking through some of the gaps in, planning, training, and exercise, and I'll talk through that. And don't know if we have any, public safety folks on this call, and I'd love to hear your experience with this. But from my experience, and I've done this for, too many times now, responded to these events. What I've seen is most jurisdictions do not have a robust fatality management capability or a sophisticated fatality management program. That's partially due because day to day, they have the ability to handle what their jurisdiction needs. And they haven't seen a major disaster like, Las Vegas did, or like New York did, or, a place like Louisiana did after Katrina, or someplace that's experienced a, commercial jetliner crash with, 200 plus people on board. Normally day to day, the coroner ME systems work fine because they're built to handle, the normal amount of people that, pass. And the more important piece day to day is that public safety response, the police, the fire, the EMS personnel to go out and, try to keep people alive. But the challenge comes when you have that bad day. If a bus crashes in a rural section of the interstate, or a plane crashes, with more than 20 people on board, I think you quickly get the picture of, now what do we do? And I can remember back in probably 2009 when I was at New York City Emergency Management, we had a bus crash in the Bronx. We had, I think, 22 fatalities, and a week later, Virginia had a similar crash, and it was in a very rural place. And state troopers called the NYPD, and they were like, "Hey, we just saw on the news that you guys had one of these. What should we be doing? And, you know, we kind of talked them through it. And, you know, again, a lot of times identification is the challenge. But that's when you pull out the plan. What does the plan say? Well, the plan gives you, you know, a couple of pages of what you need to do, but it doesn't give you any of the how. You know, how do you need to do it? So I like to use this example with my, you know, current emergency management team is when we write a plan, don't write half a cookbook, right? Let's write the whole cookbook. Don't just give me the ingredients and how to mix them together, but give me also what I got to set the oven to and what it should look like at the end and how long I need to cook it. A lot of the plans that are out there are half a cookbook. They'll take you through, here's the scenario, here's what you need to do, and then they wash their hands of it. And they don't follow through with some examples of the how. And when you hit obstacles, how you have to be flexible to make those changes to be successful. And, you know, I talked through this a lot, you know, and when I got here to Virginia, we reviewed our fatality management plan, and it had the concepts that I'm going to talk through here, but it did not have, you know, the how we can do it or who needed to do it. You know, the ME coroner never has enough staff to be able to work through, you know, all of these challenges. So on the planning side, what, you know, high level, if you're in this business, you're going to go review a fatality management plan or write one, make sure that, you know, there's plenty of them out there on the internet that are decent, but just make sure it doesn't have just the what. You know, we need to do a family assistance center. Okay, how do I do that? What are the pieces that make up a family assistance center and who needs to execute it? Make sure you take that plan to the next step and work it all the way through. That also leads to the training. So if your plan is lacking, there's nothing to train on, right? You're going to have a gap. And a lot of times, you know, understanding the plan and how to execute it is paramount to be successful. But if your plan is lacking, there's nothing to train on. So also the additional partners in the process need to be engaged and trained on the plan and what might be expected of them. So if I go back to, you know, my earlier definition of the fatality management system, it outlined a lot of different people, and I'm trying to find it in my notes: law enforcement, healthcare, emergency management, medical examiner, coroner's office. Plus, if you build in the back end of the funeral directors, especially the hospital morgue staff, you really need to make sure that everybody that's involved from beginning to end is involved with the training. So the piece that is really challenging is exercises. Everybody that's in public safety has been involved with a, you know, quote unquote, lights and sirens response exercise, where they stage a scenario, the lights and sirens go on, you race in, you do your life safety, you do your triage, you do your transport, and then they call index. And unmute. Can you guys still hear me? Okay. I just got a message that I was muted, so sorry about that. So in New York, when I was, you know, with the NYPD and with the medical examiner's office, we were doing a lot of the post 9/11 Homeland Security funded trainings, massive 700-800 person, you know, 6 to 12 hour training exercises. And the entire fatality management portion was set up the temporary morgue. We're going to bring you 1 or 2 bodies, and then we're going to call index. And there was really not a lot of engagement until we put our foot down and said, well, then we won't play. So what we asked them to do was run simultaneous exercises, because, you know, the lights and sirens portion of a response may only take 2 or 3 hours to resolve, where the FM portion may take years to resolve. And the on-scene piece may take 2 or 3 days to resolve, depending on what you have to deal with. So what I encourage you to do is, if you're in public safety and you're going to do a lights and sirens exercise, excuse me, and you think your fatality management plan is a little bit lacking, ask them to exercise it. Go through the motions just like you would if you were, doing life safety or doing a hazmat response or doing a rescue. Same thing. You're gonna perform like you train, and you need to make sure that fatality management is no different. And again, the goal is to take care of the living, take care of their families, and the decedents need to be handled in a rapid, dignified, and respectful process so that the families can, have some closure. So I'm going to just check the chat because I see something's in there. Let me see what it says. Oh, it just says hi. Okay, I'm good then. All right, does anybody have any questions? I think I got about 10 more minutes before we have to stop and take questions. So Jeff, you got a question?
Can you see it, John, or do you want me to read it?
Oh, no, I got it now. I was just going to see if you wanted to talk through it. But Jeff, did you come off mute?
I did, yes. Yeah, sorry about that. I said, hi, John, and then hit return, and I was going to type it in and forgot that actually sends that. So, yeah, so my question is, so just my career has extended over emergency management early on, and then for the past 20 years or so, I've been involved in organ donation and transplant, and I'm actually in my last class of the MPS program in public health and preparedness, and my capstone will be on the COVID's effect on organ transplant and organ donation and transplant. And so I was just wondering about your involvement with organ procurement organizations, and particularly now in the era of COVID, and how your interaction has been with those organizations and continuing to promote donation and transplant, but given the high rate of transmission.
So unfortunately, from my bio, I actually work for the Virginia Department of Transportation full-time now. I can definitely get you connected with the folks in New York that have been dealing with that. I directly didn't have any involvement with that now during COVID, but I can get you the right resource to answer that question. Day to day, my current job is, safety, security, emergency management director for, a Department of Transportation. I just happened to deploy to New York on an EMAC mission because of my background in FM and the history I have in New York. But I can't directly answer that question, but I can, if Jen, sends me your contact info, I can connect you with someone.
Hey, Jeff, after the webinar tonight, I will do a virtual intro with email addresses so that way you guys can follow up.
Awesome. Thanks.
You're welcome.
All right. I got about a page and a half of notes left. I think I can get that done in the time frame we have here, and then we could, see if we have any questions. So, all right. So, disaster and emergency response. How does this intertwine with fatality management? So, I often think through, how are disasters ranked, right? What's a good disaster, a bad disaster, what's a terrible disaster? And there's two things that always pop up. It's how many people died and how much money they cost. Unfortunately, you don't hear about the number of injuries or the families that have been displaced. It's really about money and death. The response phase of a disaster is normally relatively short until you transition to that recovery phase. Now, they do run a little bit simultaneous, but recovery can take multiple years, especially if you're dealing, with a lot of fatalities. So just quickly, every month, I still get the statistics from the World Trade Center deaths and identification. 19 years later, there's still a monthly report coming out. So does anybody know how long it's taken to identify these 9/11 victims and how many have been identified? Does anybody know? All right, so I'm going to give you a couple of numbers here just to take away. So in New York City, 2,753 people died on 9/11. So 2,753. Only 1,642, about 60%, have been identified. That means there's still 1,108 people that were confirmed missing that have never been identified, 40%. Of those, almost 22,000 remains were recovered, And of those, 67% were identified, about 14,700. 7,200, about 33% were never identified. And that's a constant ongoing process that New York City has undertaken. There's actually been new DNA techniques put into place that have been used in other disasters. I have an entire report that breaks down, how they've identified them: DNA, dental records, fingerprints, photos, remains were viewed. But think about that: 19 years next week after 9/11, 40% of the people still haven't been identified, and all of those remains, because of the amount of damage they had from the fire or being crushed, can't even get DNA from them. Or the flip side of that is no family members came forward to claim those folks or give DNA so that they could be identified. So it's a arduous, very long process. So 19-year anniversary, and it's still a daily operation in New York City to try and identify those folks. So these things are going to take a while. So a couple other terms I want you to remember. What's the difference between a closed and open manifested incident? So what does that mean? Commercial airliner crashes. There's a manifest. We know who's on that. We know who's on that plane. So we know what the victim list is. We know where to start. But if you dump a commercial aircraft into a building, we have a open and a closed manifest incident because we don't know who had come and go in that building. If a subway crashes, we don't manifest who's going on there. It's an open manifest incident. You don't have a victim list to start with. So you don't know what your starting point is. So that's when you get into starting with missing persons reporting and trying to build a victim manifest. And having a system to build a victim manifest was one of the challenges we experienced in 9/11. It's a challenge around the country because when you don't have a casualty call system, it's open season. Everybody's going to call their local police department, their local Red Cross, their local hospital. They're going to report people missing. You're going to get thousands of duplicates, which is what happened in New York. And now they have a system in place, and they've shared that in multiple places around the world, to take an open manifested incident and be able to build a victim manifest, which is super challenging. So keep that in your head. And that's a piece that you need to address if you're ever going to write one of these plans. All right, so let's talk about recovery. So fatality management recovery of the remains is a difficult and tedious process. From the investigation into what occurred to the recovery of the remains and the process to do so, to do the investigation, the identification of a decedent, either by contextual means, which is pictures, tattoos, in-person viewing, or scientific, fingerprints, DNA, and dental records. You have to determine the cause and manner of death. You have to notify the next of kin. You have to execute temporary disposition if there is no next of kin. And then you have to work with families and funeral directors for final disposition. So there's a lot of steps that we have to go through. It's very, tedious. And even within those, there's different pieces that are scientific and have to be broken down. All of these take time and resources to accomplish. Day to day, the MEs and coroners do this work, but not to the scale of a mass fatality event might pose, which is why they have to surge and request help. Something even more complicated is if you have highly fragmented remains, like from a plane crash or, like a building collapse, like the World Trade Center, collecting those highly fragmented remains is very tedious, and you cannot commingle. Just because two bones are laying side by side, they can't go in the same bag. You have to make sure you bag everything separately because you don't want to have that commingling problem. Also, if you have a fire with multiple fatalities, or you have a complex recovery because it's a chemical incident, or if you have decedents in a population that are of similar age and similar size and physical structure, you may, mis-ID them. Even if the families come to view them, they may get mis-ID'd. And I've seen that happen where we had a plane crash, small tourist plane crash, and the family ID'd one of the victims. But then when we looked at the pictures right before we released them, the clothes were different. So you had two young boys of about the same age, same hair color, same physical structure. And the family was just, you know, so upset that they mis-ID'd their son. And we ended up catching it and making sure they got the right, you know, remains. So there's a lot of complication in there. All right, so just going to talk through quickly the primary objectives of a, you know, successful mass fatality management operation, and how do you manage expectations with both the government, with your, you know, with your superiors, making sure that they understand how long this is going to take, and the families. So you need to establish jurisdictional authority and who is going to be in charge of the remains. You want to ensure that the mass fatality management operation is safe. We don't want to get anybody hurt or killed or injured during a mass fatality operation or any fatality management operation. It should be almost a zero risk. We want to take as everybody's got to come home. You know, it's not like a rescue where we're trying to keep people alive. These folks are already deceased. We want to make it as safe as possible. We want to provide family and friends of potential victims with a single centralized mechanism for reporting and communicating to the government, which is that casualty call system we talked about. Provide families with factual and timely information in a compassionate manner in advance of any public release, right? You want to be ahead of the news reports as best you can. Establish a system to support a family assistance center that allows for accurate and efficient acquisition of ante-mortem data. And I'm going to talk about ante-mortem and post-mortem data here in a minute. Conduct rapid returns of decedents to the next of kin, and provide an ongoing mechanism for family outreach. All right, so I'm going to close with the difference between post-mortem and ante-mortem collection. So post-mortem, which is the morgue operation, is when you bring the decedent to a morgue and you collect evidence and information and scientific data from them. DNA, fingerprints, pictures, any of their personal effects. They might have ID on them. That's post-mortem. They're dead and you're taking information from them. Ante-mortem data is what you get from the families. They do a missing persons report. They come to the Family Assistance Center. They bring pictures. They bring DNA samples, toothbrushes, hairbrushes, possible dental records. And that's where you start to cross the data to make an identification. So you take the post-mortem data from the decedent, the ante-mortem data from the families, and you mesh those together, and hopefully you can identify everybody. As you see in New York City, there's some gaps because we didn't get all the ante-mortem data, so you don't have a way to really put that information together. So there's one other piece, and it just escaped me, so maybe I'll grab it in here in a minute, but I just wanted to talk about that employee wellness piece and the mental health. So fatality management's super stressful, difficult work, not for everybody, right? Working with the dead is not for everybody. The things you see and the situations you come across can affect your employees long-term, even if they're not medical examiner, coroner employees. If they're cops, firemen, EMS, they're going to see these, you know, kind of horrific things, and you need to have the ability to give them an outlet. So you got to be cognizant of the fact of these factors and give your employees access to mental health services, really that wraparound service. And you got to check up on them. You can't just do it once and, you know, hope for the best. You really need to make sure that you're going through this appropriately. All right. I hope that was informative for you folks. I'm a few minutes over my time that I was allotted, so I'm going to stop now and see if there are any questions. We could have some discussion. That's really super high level, you know, fatality management, you know, 101. And, you know, if any of you folks are in this business and, you know, have some observations, I'd love to discuss them.
Thank you so much for that, John. This is something that we kind of talk around in a number of situations, but we've never really taken a good look at it, despite how important it is. So I really appreciate you being able to provide this for us. Sorry about that. Of course, he's going to start barking just as I. So we have students who are coming from a number of different backgrounds, everything from military to first responder to you know, medical professionals. But one question that I always like to ask our speakers is, our students right now are all studying public health preparedness. It's a Master of Professional Studies in Homeland Security program, and most of them are are doing public health preparedness. Some of them we have some international affairs and some other students who take our classes as electives, but the bulk of our students are in our public health preparedness program. So you said that working with the dead is not for everybody, but if somebody was interested in pursuing this line of work, what would be a really good piece of advice that you could give them on how to get into this, like what pathways to take or anything like that?
So I would say is, look, and this is a piece of advice I just gave my, senior in high school son who doesn't know what he wants to do yet for a career, but he's really a big Elon Musk fan and he wants to do something with rockets. I'm not sure what that is. So what I told him to do was, well, go online to SpaceX and Jen, I don't know if you know, in Culpeper, we have a rocket assembly place not too far from here. And
I did not.
I said, go online and look at their job postings and look at the type of education and experience that they're looking at and looking for, and try to tailor the education that you're going to get to, what those positions that you think you might be interested in. The mass fatality management is very infrequent, but they're always looking for people to do morgue operations and work their way through that. There's a lot of jobs on the forensic science side now for working in the toxicology lab or working in the histology lab or the DNA lab if they have that. Obviously being a forensic pathologist is a MD, right? You got to be a doctor to do that. But the entire support staff around that, and a lot of the ME's office now, even though they have a smaller staff, they have an emergency manager in their group that does this interaction with the other agencies just in case. Just think about day to day. If there's a crash on the interstate today here in Virginia, because we have a centralized medical examiner system, the first responders go, the local fire department, the state police. If there's a decedent there, technically the medical examiner has jurisdiction and they need responders and investigators to go out there. So there's multiple paths within the organizational chart of a medical examiner's office that have some common threads. They're going to have investigators who are either, public health professional trained or medical trained people, nurses or physician's assistants that will respond to the scene and do that investigation. You have the mortuary staff that deals with assisting the autopsies and collection of evidence. You have evidence technicians that take that evidence and store it. There's a lot of different pieces in there. But my guidance is always take a look at the job postings across the country and see what kind of experience they're looking for and the types of jobs they have. And, again, I look at job postings as what they think the job is going to be, but every job I've ever applied for and gotten was never that, right? It was always a little bit different. Like they write what the job is expected, but you always end up doing something a little different. I don't know if that exactly answers your question, Jen, but.
No, it does. I appreciate it. So JD wants to know if this job topic was something that you chose, or was it chosen for you, or was it thrust upon you?
So I didn't choose it. I chose to be a cop, and I was fifth generation NYPD. It was kind of the family business. I was on the force at the same time as my dad. He was on the same time as his dad, and so on and so forth. So I planned on being a police officer. I chose a path to join a special operations team, SWAT team, search and rescue, and learned, where we fit into this fatality management system, and built a relationship with the folks at the ME's office after 9/11, just because of the position I had during 9/11 for the NYPD and how we were dealing with the NYPD's decedents and families, and kind of learned, sometimes you just have a knack for something. Unfortunately, I have a knack for some things that, aren't very practical day to day sometimes. Public safety, I'm pretty good at it. I've made a career of it. This FM piece, I've been successful in, these large scale events. And unfortunately, when you have a little bit of experience under your belt with this, people call you back to help because they just know that it's not going to be new. you know, it's new for a lot of people in a lot of places. So if there's not a lot of us that have done this numerous times. So I chose to be a public safety professional. I think it was kind of chosen for me with heritage because of my family history with it. My brother escaped and he's a photographer. I don't know where that ended up, but I chose public safety, but this FM piece kind of just came upon me through experience.
And now you're well known all the way from here to London.
Yeah.
Okay, so like I said, I am, we've got the chat up and I've also got the participant list. So if you've got a question and you want to type it, or if you want to just raise your hand, we can just call on anyone. So are there any more questions?
Yeah, Jen, I've got one.
Oh, hey, Gavin.
Hey, Jen. Hey, John, that was a great presentation. Thank you so much. And I think where you've highlighted some of those areas where we need to, critical gaps still exist. And so some of the work that I've been working on for the last 10 years is forensic restoration. And we're looking at mass casualty cleanup, looking at crime scene cleanup. And it's really interesting how those experts right now in the sort of the restoration industry have had to pivot and deal with, again, still dealing with invisible enemies, not just bloodborne pathogens, but being able to pivot and participate at a community level on fighting, say, a SARS-CoV-2 virus that causes COVID-19. But more importantly, how we're starting to work with law enforcement and other first responders at a mass casualty scene. One, to the skill in maintaining the integrity of the scene for, again, investigation, but also ensure that we can protect the people, the environment, the buildings from invisible pathogens, viruses and bacteria that come from blood or any other bodily fluids. And it's been a real interest that in 2016 the Restoration Industry Association developed the first guidelines, and just a couple of weeks ago, after 2 years of working with the state of Georgia, we've developed the first standards for the state of Georgia in mass casualty crime scene cleanup. Where do you think this will go? Do you think we have to do this one state by one state at a time, or will we eventually have a sort of a federal guideline on mass casualty cleanup?
So the feds, please don't take this the wrong way, but I'm going to say it anyway, because that's just usually the way I do it. The federal government has basically 0 people programmatically assigned to fatality management, even though HHS owns it, I believe on the ESF 8. They have 0 people and 0 budget to do planning. And they put a lot of resources toward the recovery piece because they have the DMAT teams and they have, the DMORT teams, and they'll dispatch, their own personnel to support. But I don't think the federal government is going to wade in. Now, they did write in a fatality management section into NIMS, into the ICS structure. But when it comes to the crime scene cleanup piece, I just think because, they're probably going to hang their hat on EPA guidance for hazardous materials or CDC guidance for, cleanup, post-infection or, post, exposure to bloodborne pathogens. I just don't think, my personal opinion is, I don't think the federal government wants to wade into that past their overarching, guidance that they already have. And when I say, let me rephrase that. I don't think they're going to put any law on it, right? I think they may put out recommendations or some, guidance that's not, you're not bound by on how to do it. But I just don't think they're going to put any, boundaries on, other than, okay, EPA says this kills this and this is how you should do it, and CDC says you should do this, and this is the waiting period for this pathogen before you can get in there safely without personal protective equipment, like we're seeing now with COVID. But, I just think with all the things going on in the federal government, they more hyper-focus on other topics, and I just think they're going to leave that to industry until there's a problem. And I just don't know if, how widespread the problem is right now.
Okay, so we've got another question that asks, how do you deal with the difference in resources between states, cities, and towns, considering the differences in funding at each of these levels and upkeep of critical infrastructure?
Yeah, so I like to take a page out of FEMA's book where they say all disasters are, locally managed, state supported, and I forget what the federal government is, something like that, right? So the locals own it, the state supports it and the feds come in and, prop it up and push money into it. It's really a challenge because, even here where Jen and I live, there's competing resources in the budget, right? If you take money out of the school budget and give it to the public safety folks, well, then, there's a possibility that you have a gap in the schools. Well, you really have to, manage that. And especially, in the next 12 months with the decreases in revenue from, COVID impacting the budget. And, I work for the state of Virginia. I know, what our financial situation is. And right now we're in good shape, but I also know the situation that New York City's in because I talk to them every day. One of the biggest cities in the world, and they have a almost $9 billion budget gap, right? They're talking about layoffs and they're talking about cutting services. I think when I worked at State Emergency Management here in Virginia, we were very aware of the, smaller, more rural jurisdictions and what their capabilities were. And we would try and push them state resources sooner. Obviously, Arlington and Alexandria and the bigger places in Fairfax County here in Virginia, they have robust emergency response systems and significant amounts of training and personnel. We didn't have to push them as much. We would push them as much resources on the front end to, make a problem go away. So it's really, if you're a local and you don't have a lot of capabilities, you try and write grants, you try and get additional funding. But you really need to work with the state and see what capabilities the state can support you with. Now, here's an interesting discussion for probably a future class that you have, Jen. I don't know what the answer is, but if a local county shuts down their police department, normally the state police will come in and help do 911 response. Most of the country, I've seen that, a lot of small rural counties don't have their own police department. They rely on the state police. But if they don't have that local volunteer fire department, where are they going to go to get EMS and fire support? Well, they could possibly contract with the, next town over, but that really delays their response. It is a challenge. There's no backstop on the fire department side like we kind of have. Every state or Commonwealth has a state police that can come and backstop the locals if they need it. We don't have any, I don't think any jurisdiction in this country, has a backstop for the fire EMS system if their local system collapsed for whatever reason. So I think you just have to be aware, if you're a local emergency manager, you got to work with your state and work, mutual aid, make sure that, the local surrounding counties are able to support each other. There's never enough money to go around. I, unfortunately was responsible for dishing out the grant money a couple of years ago for Virginia. You don't make any friends, they put in requests and you have to, gauge them on risk and do risk assessments, and you never make everybody happy. And then, again, the feds are there to really not be first responders. They're there to really backstop when you have a major disaster and, push through grant funds, in blue sky days.
Hey, JD, do you have a question? I see your hand raised.
So when you are fighting for funding like that, and you talk to one of my other classes with Professor McGregor Skinner's on exercises, how do you, when you're hunting for money, do exercises for fatality management when no one's giving you any money for it? So is it relegated to tabletops? Is it, how do you work that in?
Yeah, so, the way we did it in New York was when we wrote the proposal, we would build the fatality management component into our proposals for grant money. Locally, if you're using local money for exercise, you really just have to stress the importance and the technical aspect that needs to be put in place here. I'll give you a scenario that's super complicated. We have 2 nuclear power plants here in Virginia. One is here in the county I live in. If we had a nuclear event at that, a meltdown or a leak, and we had people chemically contaminated, radiologically contaminated, and they die, where are they going? What are you doing with them, right? That's not in anybody's plan. CDC has a plan because we helped them write it when I was in New York City. But you have to stress to the local, budget people, the local fire chief, the local sheriff or police chief, of the importance of how complicated this is going to be. And you have to just, you know, plead your case to carve out a section of that exercise to kind of do this. And the way we landed in New York was concurrent. We would do concurrent exercises, right? Because they're going to do their lights and sirens exercise. They have to, right? That it's good for the public to see that the public safety folks are out there training and doing exercise. And you could hide the fatality management piece under a tent somewhere, but you need to bring, you know, decedent, you know, mannequins from the scene, process them through some kind of disaster morgue. How are you going to move them to? How are you going to collect evidence off them in the field? How are you going to do a field investigation, you know, and capture the data that you need to get that post-mortem collection started? And I think the challenge that most jurisdictions have is they don't have the sophistication in their system to be able to explain why it's so important, right? I think if you truly build your plan and understand all these steps and be able to plead your case of, well, this is going to happen at some point, especially, you know, if you're in a larger jurisdiction, they seem to repeat themselves. You need to stress, okay, here's a gap. One, we don't have a way to build a victim manifest. It's going to be all over the map. Oh, that's only a minor problem. We don't have a really good way to collect post-mortem data or ante-mortem data. Like, what's our family assistance plan? What's our disaster assistance plan for the families and to get them information? And when you build in those complexities, first of all, you'll have their heads spinning, and then you can compete for, and you got to, if you haven't done this, you got to start small. And maybe it's a tabletop, or maybe it's just a facilitated discussion on the front end, and you build toward 2 and 3 years later doing, you know, that full scale FM exercise. It's got to be building blocks. And, you know, money's a challenge, right? Sometimes you don't need a lot of money to do these things. You could, you know, you could spitball this on a webinar and just talk through on the front end, hey, what's our plan for building a victim manifest, and how are we going to do that, and how are we going to work with the Red Cross when they turn on their casualty call system, but they don't openly share the data? Like, how are you going to work through those challenges and at least get that conversation started? And if you break it up into, you know, eat the elephant, you know, one bite at a time, you compartmentalize these kind of high level things I talked about, it'll build you toward that better plan, and then build goodwill toward how do we exercise this effectively. I don't know if JD, if that helps you or not.
Very much. Thank you.
Okay, so I don't see any hands raised, and I don't see anything in the chat. So last call for questions. Going once, going twice. All right, I think we're good. Jean, did you have anything else?
No, this has been great. Thank you, John. Really appreciate it. Jen, thanks for setting it up, and everybody, thanks for attending. This was very good.
Yes, John, thank you so much. This was great. I really appreciate your time.
Oh, no problem. I, you know, appreciate you guys having me, and now I know that you're local. I'll reach out.
Sounds good. Well, thank you again very much. Yes.
Global campus, yeah. So I do want to plug the picture that, I don't know if you could see it behind me because of the lights, but you know, with 9/11 coming, you know, please make sure, you know, you stress to all your students and everybody, you know, take that moment of silence, you know, on the 11th. And the reason why a lot of us are, you know, still heavily engaged in this is to try and make sure that doesn't happen again. And if it does, you know, that we have the right capability to address it and, you know, really take care of the families and take care of anybody. But a lot of, you know, people point toward 9/11 a lot, but they don't truly understand that it changed the structure of government and Homeland Security. And a lot of these programs probably didn't even exist, you know, prior to that. So let's just make sure that we, you know, that old never forget tagline doesn't go away. And, you know, I have, you know, commissioned artwork behind me, and I have another one to the right of me, you know, of the same scene that one of our NYPD photographers took. And they travel to every office I work in. Happen to be working from home now, so I have them here. But when I would go back to my office at VDOT, they come off the wall and go with me. So just please share that message.
We will. Thank you. All right. So, okay, one more last call. Nope, I don't see anything. So next month, again, it's going to be the first Wednesday.